So today is Department of Medicine turn to host the CPC, and we have a lineup 4 beautiful women to become the panelists today. So the presenter will be Dr. Ilyana Jamaludin. She's our registrar from Department of Medicine. Dr. Ilham, our endocrine fellow in endocrinology unit. And then we also have invited Associate Professor Datin Dr. Shahizon Azura from a radiologist from Department of Radiology, and Dr. Jasmine Kueh from Department of Pathology to help with the diagnosis. So to begin with, may I call Dr. Ilham and Dr. Ilyana to come to the stage, and there will be question and answer between those two, and there might be a question from the floor as well. Thank you.
Assalamualaikum and very good morning to professors, doctors, medical students and audiences, and especially our registrar today, which is Dr. Ilyana. So we better get started with the case that we have for her. So Dr. Ilyana, this patient is Miss SM. She's a 14 years old girl, previously healthy, presented with 10 months history of weight gain, 15 kg associated with polyuria, polydipsia and secondary amenorrhea. This is about 9 months duration. She's the only child and her mother has underlying Graves' disease. So what further information would you like to elicit from this brief history that I just given to you?
Bismillahirrahmanirrahim. Assalamualaikum. I will try my best to answer the questions. Okay, so in this patient, I have identified that the patient is mainly presented with 3 clinical issues, which are polydipsia and polyuria, weight gain, and also secondary amenorrhea. So I will begin asking questions focusing on each clinical issues before moving on to more general question. Okay, as for polydipsia and polyuria, I would like to know the onset, whether it is gradual or abrupt. And then, is there any constant need for fluid intake at night or any craving for cold water, as this would point towards diabetes insipidus. I also want to quantify the total fluid intake per day and also how much the patient urinate per day, the frequency of urination or nocturia to confirm through polyuria. As for weight gain, I would like to ask whether the patient has any Cushing syndrome symptoms such as proximal muscle weakness. Patient may have difficulty in combing her hair or undress, any easy bruising, worsening acne, change of voice, or even any increment in waist size. Any symptoms of gigantism such as headache, sweating, change in facial features such as the skin become more coarse or oily, or any rapid increment in the shoe size. As hypothyroid can also cause weight gain, so I would like to ask any symptoms of cold intolerance, mood change, bowel habit change, fatigue, and irregular menses. Lastly, I would like to ask whether the patient developed any complication from the weight gain itself, such as OSA. So the patient may develop snoring, early morning headache, or daytime sleepiness. For secondary amenorrhea, I would like to know about the age of menarche, the menstrual cycle prior, any nipple discharge, specifically milk discharge to suggest galacturia, or any excess of body or facial hair. Other things I would like to ask about blurring of vision. The patient may have difficulty to read on the board or screen, or frequent bumping into objects or person beside, or missing ball while playing sports. Any constitutional symptoms such as fever, night sweat, loss of appetite, or chronic cough to suggest malignancy or chronic infection. Any trauma to the head, And then I would like to explore further the diet history, lifestyle, and also physical activity. Family history of malignancy, autoimmune disorders, or endocrine disorders such as familial Cushing, congenital adrenal hyperplasia, or PCOS. And socially, is the patient sexually active? And I want to ask whether patient ever consume supplements that contain steroid, oral contraceptive pills, antiemetics, opioids, antidepressants, or antipsychotics.
Right, that's very lengthy questions you want to ask about the patient, but probably because the stems that we're given is a bit broad. So to just give a brief idea about this patient, I separated in, since you've been asking according to the symptoms that the patient presenting. You were saying a polyuria. How you define a polyuria beforehand?
True polyuria is when the patient urinate more than 3 liters per day or more than 50 mils per kilo per day.
All right. Okay. So the polyuria and polydipsia symptoms that patient been complaining is actually first feels thirsty most of the time. She does not have a specific time and specific to cold water. She's been drinking about 4.5 liters per day, passing urine about 5 to 6 times. When we asked about quantification, she was saying about 4 liters. Having heat intolerance, worsening gradually over 10 months. So with regards to weight gain, it's unintentional. She has been gaining from 63 to 78 kg in past 10 months. However, there's no headache, no proximal myopathy, no hot flushes or palpitation, no diarrhea. The bowel habits has been normal about 1 to 2 times per day. With regards to the amenorrhea, she had her menarche at 12 years old. Her last menses was about 9 months ago. Previously, it was regular, 7 to 8 days every month, and she has no dysmenorrhea. She denied hirsutism, deepening of voice, and also worsening of acne. She has on and off blurring of vision, but it's not disturbing her daily activity. She still can go to school and do her homeworks and all. There's no galactorrhea, no snoring, no chronic cough, no constitutional symptoms. She did not have any history of trauma or fall. Her diet has been normal for a child, 3 meals a day with no increase in food intake for the past years. So there's lack of exercise. She's busy studying. She's a Form 2 student. Other than that, she's not on any medication except for vitamin C. Her mother had a graft disease, as mentioned earlier, but also have a hypertension. Father had a diabetes mellitus and IHD. However, passed away at 50 years old. There's no family history of malignancy. She's the only child living in Bintagor, Sarawak. She's a student Form 2. She's not in any relationship and not sexually active. She's also non-smoker and non-alcoholic. Basically, she has no high-risk behavior. So anything that you want to elicit before we go for the examination from the history? Anything more that you want to ask?
I think that's enough. No further question.
Okay. So these are the examination briefly that we give to you, whereby patient initially presented with a blood pressure of 158 and 89 millimeter mercury. Her heart rate was 96 beats per minute. She's afebrile. Her height was 153 with a weight of a 78.8 kg and BMI of a 33.6. Her waist circumference was 104. So what would you expect to elicit from the physical examination given the history that we've just given?
Okay, from this stem, I can see that the patient is hypertensive with mild tachycardic. She is obese in class 2 with central obesity. So I would like to conduct my physical examination from head to toe. Generally, I would like to assess the hydration status. And then from the face, I would like to see is there any moon face, facial ptetora, acne, thinning of skin, hirsutism or deepening of voice. The skin texture, is it coarse or oily? Any prominent supraorbital ridge, prognatism with increased interdental space, or macroglossia, or flushing, or even alopecia. And then I would like to perform a visual confrontation test to detect any visual field defect, specifically bitemporal hemianopia. And I also want to look, is there any ophthalmopathy? And then at the neck, I would like to see, is there any goiter, lymphadenopathy, acanthosis nigricans, to suggest insulin resistance. And then I would examine the lung to assess the breath sound, to elicit is there any mass, and then assess the apex beat and is there any ventricular heave. I want to see is there any galactorrhea from the breast, from the abdomen, is there any violaceous striae or any palpable mass, and then from the limb, is there any proximal myopathy, violaceous striae, ecchymosis, thinning of skin. And I would like to grade the pubertal development by grading the breast and pubic hairs according to the female tenor stage. And I want to see is there any clitoromegaly.
So would you mind to just describe what is acanthosis nigricans and also violaceous striae?
Okay. Violaceous striae is a red and purplish striae that is usually more than 1 cm wide, that can be usually seen in the Cushing syndrome. And then the acanthosis nigricans is hyperpigmentation that occur due to the insulin resistance.
Right. Can I ask one question to Ilyana? Why you said clitoromegaly as part of your pubertal development assessment?
Actually, no, Prof. Actually, it's included under others, not under pubertal development. I mean,
okay, right. Why do you want to look for clitoromegaly? You know, you have the history, quite a lengthy and complete history given to you. You asked Dr. Ilham, what is your differential diagnosis that made you think that you want to look for clitoromegaly?
Okay. The reason why I want to see clitoromegaly is to see whether the patient got signs of hyperandrogenism, specifically congenital adrenal hyperplasia that may have clitoromegaly.
Right. From the history, does that suggest that she has hyperandrogenism?
From the history itself, no, Prof.
Right. Thank you.
All right. So I'll just give you a brief examination. I know this is a bit long, but we pick up a few findings from her, whereby her hydration was good, the tongue was not coated. She has moon-like faces with mild clitora. Supraclavicular pad is present. Her skin is thin and looks easily bruisy. There's hyperpigmented over the creases. With regards to the cardiovascular, there's apex beat is not displaced, dual rhythm, no murmur. Her lungs is quite clear. There's no evidence of mass. Abdomen, there's a truncal obesity with a purplish abdominal striae, and bilateral lower limb striae is also present with a proximal myopathy. So visual field was normal. There's no hemianopia, and breast and pubic hair tenor 4, right? So what are your differentials at this point of time? We know that we give you a few stems only. You may just list down your your differentials, and we go through from that.
Okay, based on the information that I have gathered so far, the patient presented with weight gain, polyuria, secondary amenorrhea, and from physical examination, she has Cushing features. So the top differential diagnosis that I have in mind at this point is Cushing syndrome, whether it is ACTH dependent from the pituitary or ectopic, or ACTH independent from the adrenal. Okay. Other differential would be polycystic ovarian syndrome or metabolic syndrome. And then, since this patient also has true polyuria, my differential diagnosis would be diabetes insipidus, either cranial or nephrogenic in origin, or the newest term that we have now is AVP disorder. And also, I want to rule out a primary polydipsia as well. And then another differential would be hypothalamic pituitary mass, which may include pituitary adenoma or craniopharyngioma, and the rest, which is least on the list, is hyperprolactinemia, pregnancy, and hypothyroidism.
All right. So if you are given you like 5 differentials, which one of these that you've listed that would be high priority for your differential diagnosis?
It would be Cushing syndrome, more likely ACTH, dependent from the pituitary, and also diabetes insipidus.
All right, that's 2.
Diabetes insipidus from the cranial, yeah.
Okay, so we'll just go through. This is the information that was given to you initial investigation, the basic investigation. Would you want to comment and let us know what investigation that you further want to do?
Okay, from this blood test, I can see that there is a hemo concentration as evidenced by high hemoglobin at 16, high platelet 482, and hematocrit is high at 49. Patient is hypernatremic with sodium of 151 with normal potassium. There is mild transaminitis with impaired fasting sugar and pre-diabetes range of HbA1c of 6. There is no features of UTI from the UFEME.
Right. You mentioned the results which we can also read. What is your interpretation of whole blood count and what can cause that hemo concentration based on your history and physical examination?
Okay, from the physical examination and based on the blood investigation and physical examination, the cause of hemo concentration with hypernatremia is likely due to the diabetes insipidus, Prof. And the cause of impaired fasting sugar with transaminitis may be because of the Cushing syndrome.
Right, diabetes insipidus will not cause hemo concentration or high hemoglobin. What could be the most likely cause of hemo concentration and high hemoglobin here in this young lady?
The dehydration?
No. Not in this case, in diabetes insipidus.
Not in this.
What can stimulate the hemoglobin production? Based on your physical examination findings that's given to you and your diagnosis.
Is it?
Okay.
I'm sorry.
Okay.
So is a weight gain, and also the patient is having a plethora, which is the signs of hemo concentration of the patient. Prof? Is that what you're trying to ask her?
No. What hormone can cause hemo concentration or increased production of hemoglobin? This in your history and your physical examination.
Based on your history.
It is your differential diagnosis.
This one of the differentials.
The Cushing syndrome?
Yeah, cortisol.
So what further investigation would you like to perform?
Okay. For the investigation list, I like to categorize the tests as biochemistry, hormonal panel, dynamic test, and imaging. So the first thing that I would do is the basic biochemistry test. First, I want to do UPT to exclude pregnancy. And then I want to see the electrolytes, whether is there any hypercalcemia that can cause polyuria. I also want to send a PET sample of urine and serum sodium and osmolarity, the fasting serum lipid, CRP, ESR, and LDH to exclude any infection, inflammation, or malignancy. For the hormonal panel, I want to see the thyroid function test, the AM cortisol, 24-hour urine free cortisol times 2 as part of the screening for Cushing. Also pituitary hormone panel, such as ACTH, FSH, LH, prolactin. Since this patient has no features of gigantism, I would probably not sending IGF-1.
Right, before you go on further, Dr. Ilyana, I think there's a lot of tests that you want to send. I think we don't actually send all the tests. Dr. Ilham, do we send all the tests that being requested here? Usually, the tests that we request, that you should request, should be based on your history and physical examination and your differential diagnosis. Because the further tests that you request should be the test that will clinch to your diagnosis or help you in making a diagnosis.
These are the list that you give beforehand of knowing the history, full history and examination. Probably you would want to just highlight the test that you really would want to send for this patient.
Okay, my priorities would be the thyroid function test, AM cortisol, ACTH, 24-hour urine-free cortisol times 2, FSH, LH, and also prolactin, and ARR.
Would you want to send a CRP, ESR for this patient?
No, at this point, no.
And also LDH?
No.
Yeah, all right. All right, so we shall proceed with the brief biochemistry and hormonal panel that you asked. So this is investigation. Give you a few times to just absorb and try to interpret.
Okay. Okay, from this information, I can see that the electrolytes are normal. There is a dyslipidemia. The PET sample showed elevated serum osmo with a diluted urine osmo. And this diluted urine osmo is also supported with low urine specific gravity.
So other than that, how about the cholesterols?
Dyslipidemia.
In view of
in view of the high cholesterol and also in view of the high cholesterol level.
So this the hormonal panel. Again, is quite a busy slides. I've highlighted few abnormal results for you to try to interpret and probably come with what you think the patient has at this juncture.
Okay, from here I can see that the AM cortisol is very elevated. So the patient may have hypercortisolism. However, the 24 hours urine-free cortisol is within normal range. There is discrepancy in urine collection volume and her reading in both samples. It may be incomplete urine sample collection. And then the ACTH is inappropriately normal in this patient. Looking at the high cortisol, the DHEAS is elevated. Plasma renin activity, this is the ratio. What? Oh, okay. The ratio of the aldosterone renin ratio is 6, which is unlikely to have primary aldosteronism. Normal thyroid function test. And this patient also has a hypogonadotropic hypogonadotropic hypogonadism, and the prolactin is also suppressed in this patient. The overnight dexamethasone suppression test, the cortisol failed to suppress, so this patient is confirmed to have Cushing disease. Sorry, Cushing syndrome.
Why did you say this patient is confirmed to have a Cushing syndrome?
Because with the dexamethasone, it failed to suppress the cortisol to less than 50 nanomole per liter.
If I may ask, what are the confirmatory tests for Cushing syndrome that you know?
The confirmatory test is low-dose dexamethasone suppression test and also the ODST.
The confirmatory test for Cushing syndrome? Initially, why did you ask for 24-hour free cortisol? Urine free
It is
cortisol?
part of the screening.
Yeah.
Screening for the Cushing syndrome.
All right. So does this patient fit confirm as a Cushing syndrome at this point?
This patient, because I suspect there is incomplete sampling from the 24-hour urine-free cortisol. So the other test that we can do is overnight salivary test, but it is not widely available. And yeah, but looking at the morning cortisol level, that is very elevated. So this may suggest that patient may have hypercortisolism, and it is confirmed with the overnight dexamethasone suppression test.
All right. Overnight dexamethasone test is just a screening. You need another test to confirm that this patient is having Cushing syndrome,
Low-dose
right?
dexamethasone suppression test. Sorry.
Yes. All right. But we don't do another overnight dexamethasone test. And given of this, our facilities may not be able to provide, but high tendency of this patient probably having a Cushing syndrome. Any more tests of dynamic testing that you wanted to do for this patient with the results that we have given you?
The ACTH. Okay, since the ACTH is inappropriately normal at this patient, so I'm suspecting, so I can say that this patient is ACTH dependent Cushing. So it's either, the source is either from the pituitary or from the ectopic. So the further dynamic testing that I would like to do is IPSS and also for the IPSS and with the imaging MRI pituitary.
How about the PET sample that you did just now?
Okay, yeah, the urine is very diluted, so I would like to proceed with the water deprivation test with desmopressin response.
Can I ask Dr. Ilham, why was aldosterone and renin sent for this patient?
Yeah, because initially they wanted to rule out a young hypertension. She did present with a BP of 150, 160. Diastolic was 80 to 90. It was sent beforehand.
I thought the features of Cushing is very obvious.
Yes. Yeah, it was sent beforehand. Before came to us, because this patient is actually a referred case.
Right, thank you.
So yeah, this was your differential diagnosis earlier, and Actually, this is the water deprivation test of the patient. I give you a bit more time here, but yeah, probably you can just briefly interpret the results. Maybe just try to focus to areas that you need to focus on.
Okay, there are two phases here. For the phase 1, the aim is actually to differentiate whether this patient has primary polydipsia and also diabetes insipidus. So I would like to focus more on this urine osmo. We can see that after 6 hours of fasting, the urine osmo failed to concentrate. However, the urine osmo failed to concentrate after 6 hours of fasting. And then after given with desmopressin, I can see that the urine osmo able to concentrate more than 50% from baseline, and the urine volume also decreases. So this indicate that this patient has cranial diabetes insipidus.
Right. Just for the benefit for our audience, basically the phase 1 is done. It's not 6 hours; it's 8 hours. So we truly want to differentiate between diabetes insipidus and primary polydipsia. So you would want to see if the serum osmol is increasing, meaning patient is already got into dehydration after you fast the patient for 8 hours, and you want to see if the urine osmol able to concentrate or not. And if it's urine osmol is more than 700, it's actually primary polydipsia, so you won't be need to go for the second phase. But since this patient is not more than 700 and it's still low, so proceeded with the phase 2, and we've given desmopressin 2 microgram, and as what Dr. Ilyana just mentioned, it become concentrated. So when urine osmol increase more than 50%, it's a cranial DI, right? So what other investigation or images that you want to do? You did list adrenal, CT, MRI.
So at this point, I would like to request for MRI pituitary.
So this is the MRI of the patient. Would you want to just briefly tell us what is the MRI and also focus on where you want to see exactly the abnormalities?
Okay, I can see that this is MRI in T1 sequence in coronal and sagittal cut. So the area that I would like to focus is at this area to see at the pituitary stalk and also the pituitary gland here and also here.
All right, so just a bit more closer, but sorry for the image. Do you find any abnormalities at all?
I can see that the pituitary stalk, it looks normal to me. However, from the coronal view, the pituitary stalk is, I think it's kind of a bit of deviated to the left here.
All right. Why do you say this is a T1 weighted MRI?
Because the CSF is black.
Because the CSF is black, if people didn't see. So this is a bit difficult question for her. Shall we invite?
Maybe we invite.
Shall we invite our radiologist, Prof. Shahizon, who is expert in this, to just give us a brief on the patient's MRI pituitary.
Thank you very much. Assalamualaikum and a very good morning to everyone. I'm going to show you the MRI pituitary for this patient. Okay. So this is MRI pituitary for this patient. Usually it's done with small field of view, mainly to concentrate at the region of interest, which is the pituitary fossa and pituitary gland. And in this patient, tak boleh. Oh, ni pula. Okay. So this is a T1 weighted. The normal MRI protocol would include a T1 weighted, a T2 weighted, as well as a T1 post-contrast. And usually it's done using sagittal and coronal plane because these are the two planes that best will show you the pituitary gland. It is such a small structure, that's why we have to do a small field of view. And in this patient, at the age where she presented, it was about 13 years old when the scan was done. The pituitary gland is normal in configuration and size. You can see that it sits here in the pituitary fossa, which is located just above the sphenoid sinus, which is best seen here on the sagittal and the coronal image. Other than looking at the pituitary fossa, we have to look at the surrounding structures as well. The optic chiasm looks normal. The cavernous sinus as well as the internal carotid artery in the cavernous sinus also looks normal. So grossly in this patient, we don't really see any obvious abnormality. But we know that this patient presents with sign of symptoms of a lesion that probably is present in the pituitary gland. So one way to do it is to do a dynamic scan. Okay. So what is dynamic scan? Okay, a dynamic scan is when the images are acquired rapidly with a constant time interval of about 20 to 30 seconds after contrast injection. Why we do this is because we want to see how the contrast flows into the pituitary gland. First, to enhance would be the pituitary stalk. Then the contrast will then flow inferior peripherally to enhance first the posterior lobe. Only then the anterior lobe is enhanced. This is important because microadenoma, a tumor, usually would have a less dense vascular network compared to the pituitary gland. So the contrast will reach the tumor slower than the normal pituitary gland. And how we see it on scan will be that there will be a delay enhancement of the lesion compared to the normal pituitary gland. But at one point, when the time is enough, the tumor and the pituitary gland will enhance homogeneously. So let's concentrate on this particular patient. And as Dr. Ilyana has mentioned, the stalk is deviated slightly to the left side. Usually it is a central structure. It has to be in the center. So what does this tell you? It means that there could be a lesion on the right side which is pushing the stalk away to the left. And here, I hope you can appreciate at 50 seconds, the stalk has already enhanced. The pituitary gland has vaguely enhanced, and there's a little bit of asymmetry, whereby the right side has got sort of like a nodule, which is enhancing less than the left one. And this is better seen on the subsequent scan taken at 75 seconds and 95 seconds. And you see that the enhancement pattern of the adenoma, you can see a little bit more enhancement as the time passes. Now let's have a look at this scan which was done of the same patient, done at 180 seconds. Usually this is the scan that we do in a normal pituitary gland, usually acquired around about 3 minutes after injection of contrast. You can see that the gland enhances homogeneously, meaning that the lesion that we saw earlier, it wasn't seen. So I'm stressing here the importance of doing a dynamic scan when you suspect microadenoma. This patient also has symptoms of diabetes insipidus. So if you look at the MRI here, a normal scan on sagittal, this is how a normal stalk should look like. It has to be thin and has V-shaped configuration. As compared to the lesion, I hope you can appreciate that there's a little bit of focal bulge there, meaning that there could be a lesion there. So in conclusion, this patient has microadenoma, and the location is at two places, which is in the stalk as well as the pituitary gland on the right side. That's all for me.
Thank you very much, Prof. Shahizon. It's very clear. So, Ilyana, we are not yet done, unfortunately. So, at this point, how would you manage this patient? Would you do any more investigations, or you would want to start the treatment on this patient straight?
Even though, from the MRI, even though there is a slight deviation of the pituitary stalk to the left, but the size is very small, and I would like to proceed with the IPSS actually to lateralize, to confirm the lateralization.
When you say the size is small, which one? What are the cut point of pituitary size that you wanted to proceed with?
Less than 6 mm.
So yeah, again, unfortunately, you have these busy tables for you to interpret. I hope you can try to interpret this. Just focus probably on the ratio. Yeah.
Okay, so yang ni memang dah tulis ratio. Okay. Right. Okay. From the ACTH table at baseline at 0 minute, I can see that the ACTH IPS to peripheral ratio, right and left, is more than 2. And after the desmopressin stimulation, the value is more than 3, especially in the right. So this suggests that the source of the ACTH is from the pituitary, not from ectopic. And then the right and left ratio is more than 1.4. So this also support that there is the location of the adenoma is on the right.
Very good. So people are saying that I'm cruel to give this to her. We're just trying a bit, probably. She can still.
Okay. However, if I want to see at the prolactin ratio between the IPS and the peripheral, so if the value is more than 1.8, it would suggest adequate cannulation. However, on the left, I can see that the value are all less than 1.3. So this may indicate that the catheter is not properly cannulated over the left side. But and then I would like to see at the prolactin adjusted ACTH or normalized ACTH ratio, the value is more than 1.3. So this suggests the source is from the pituitary, not from ectopic.
Excellent. Can just give her a clap. This is a very difficult question. Believe me, she doesn't know this. Okay, all right. So just for the benefit of all, basically what we see is the IPS peripheral ACTH ratio, which actually showing more than 3, suggestive of pituitary source after desmopressin test. And we would see the ratio between right and left to see whether it's lateralized to the right or left. And if it's more than 1.4, as what Ilyana has just said, it's more likely right side lesions. But given that this patient, we need to know whether this is actually cannulated properly. And to prove that it's a proper catheterization, it should be more than 1.8 ratio for the prolactin IPS to periphery ratio. And after that, given that the left side, if you can see, is actually less than 1.8. Hence, you should be doing an adjusted prolactin to ACTH ratio, which all has been showing more than 1.3, and it's suggestive of pituitary. Yes, Prof.
Right, just a comment. Usually, if from dynamic test you are able to localize the nodule, IPSS is not needed, because IPSS is needed for lateralization when both sides are equivocal, meaning you can't see the nodule.
Yeah. All right. Okay. So, what is the most likely diagnosis after all the tests and the things that we have done? Would you want to summarize and?
So this, I will try to summarize what I have gathered so far. So this is a 14-year-old girl presented with Cushing syndrome and also polyuria. So from the investigation, it shows that this patient has ACTH-dependent Cushing from the pituitary, as well as cranial DI.
All right. So how would you manage this patient then?
Okay, since this patient is young, and actually the first line management would be transsphenoidal pituitary adenectomy, because we want to prevent further complication from the hypercortisolism. Okay. However, if the patient refuses, then we may offer medical therapy or radiotherapy.
All right. So briefly, just that that is the thing that at your level should know that you should operate if this is actually primary source from the pituitary, and subsequently if it's already advanced or patient not keen, then probably medical therapy or radiotherapy. So for this patient, we actually did a MDT discussion and proceeded with a transsphenoidal surgery, and intraoperatively noted 2 separate lesions, which is one in the posterior aspect of the right pituitary lobe and another one in the infundibulum. And it was successfully removed and sent for histopathology. So I would like to invite Dr. Jasmine just to brief us on the findings of the histopathology.
Morning, everyone. I'll walk you through the histopathology findings. Okay, so the specimen that we received is 2 specimens. The first one is the right pituitary lobe, which is in fragments, as you can see. Okay, and the second one is the midline pituitary tissue, which is also in fragments. Okay, so before we dive into the morphology of our case, just to highlight to you, the normal anterior pituitary gland is composed of a few different types of cells with different cytoplasmic staining properties. So like the basophils here, we have more purplish cytoplasm, the acidophils, more eosinophilic, so more pink, and the chromophobes, which is a more clear cytoplasm. And they are arranged in this nested arrangement. So this nest is actually highlighted by the reticulin stain, as you can see on the right side here. Okay, so I put A and B next to each other so that you can see that they're essentially forming the same kind of morphology. So they have similar morphologies, and they are composed of these cells, which are no longer in their nested appearance anymore. They are now in this sheet-like structures. Okay, sorry for that. So just now the solid configuration, and also they're having this acina configuration as well. So basically you cannot see the nest anymore. Okay, on higher power, we can see that the cells have very monomorphic rounded appearance. So you can see A and B essentially similar morphology, and they're hypochromatic. You can see the nuclei, they're more purple. And actually, if you can see in the higher power, which I cannot capture, they have this vesicular chromatin, which is reminiscent of neuroendocrine cells. Okay, so just now we saw the normal pituitary gland, which is surrounded by this, they are formed in nests, which you can see it highlighted by the reticulin stain, and this is lost in the pituitary adenoma. And they are positive for ACTH, LH, GH, TSH, and likely positive for FSH and prolactin. So this is our diagnosis. A and B is consistent with pituitary adenoma. Thank you.
Thank you very much, Dr. Jasmine. So in summary, what we have is a 14 years old girl presented with weight gain, polyuria, polydipsia, and also secondary amenorrhea. She had appearance of a Cushingoid and also had high blood pressure upon presentation. Biochemically dynamic testing showing a central diabetes insipidus with ACTH-dependent Cushing syndrome from pituitary source, and MRI showed there's a right adenoma with stalk thickening, possible of a 2 lesions, which was confirmed intraoperatively. And histopathologically shows it's a functional tumor. So this is a rare case of a double pituitary adenoma. I'll just go through this as fast as I can, whereby a patient have a Cushing disease complicated with diabetes insipidus. So just a bit of a progress after the operation, patient rendered into panhypopituitarism requiring replacements, and bone density scan was done to rule out if there's any osteoporosis. Subsequently, she actually able to weight reduced to 60 kg from 78. And subsequently, this is actually currently 6 years after the operation and all. She able to finish her SPM, now working her own bakery, which means she has a very good ADL afterwards, and weight do climb because of the sedentary lifestyle. But there's no more polyuria, nocturia, and she's been drinking just about 2 to 2.5 liters per day. She's clinically euthyroid with the replacement. As you can see, the BP is actually normotensive without antihypertensive. HbA1c is 5.1, given that when she presented, it was a pre-diabetic level. And MRI for just to see whether there's any residuals or any recurrence or not, showing a normal MRI. No residuals or recurrence. And we're able to taper actually the hydrocortisone to once daily. She's no longer requiring desmopressin, and only on levothyroxine, right? So just for the benefit of medical student, if still here, so Cushing syndrome is where you have a physiological glucocorticoids. It can happen exogenously or endogenously, and if endogenously, whether it's ACTH dependent or independent. So early diagnosis as for our patient is very important to avoid all the complications, right? Those who like mnemonics can have this. But what's important, we have to know what is the cardinal sign of Cushing syndromes, whereby if this patient have these 5 signs, especially, you should be worrying if this patient having a Cushing syndrome and do a test, which are proximal myopathy, easy bruising, violaceous striae, as what Dr. Ilyana just mentioned, facial plethora, and osteoporosis or osteopenia, right? So from the JCM guideline in 2022, just to bifurcate whatever Dr. Ilyana just said. So we have 3 screening tests, which is ODST, so ODST, 24-hour urine cortisol, and also late night salivary test is your screening test. But for you to confirm it, you need 2 tests of this, but ODST is not supposed to be repeated twice, all right? So ODST for patients who with OCP or in pregnant, it may show a high positivity, so you shouldn't be doing in pregnant lady, and it can give a false negative in low albumin or CKD patients. With regards to the 24-hour urine and also late night salivary, you need at least 2 because it's a daytime, maybe vary, hence you need 2 results. Low dose suppression test is actually a second line, it's not a first line for screening. And the new thing is that we have a scalp hair analysis nowadays, but we don't have in Malaysia yet. This can be very good, high sensitive in Cushing syndrome, but more of a cyclical lah. All right. So this one you can find our MEMS guideline last year. Just focus on the Cushing syndrome, whereby once you confirm this patient is Cushing syndrome, you should look at the ACTH. If the ACTH is normal or high, then you should be doing MRI. MRI, or even IPSS if it's less than 6 millimeter. As for this case, it's less than 6 millimeter, hence we proceeded with IPSS. All right. Why is that important? Localization. So in endocrine, you have screening, confirmatory, localization or lateralization. So localization, given that this patient is ACTH dependent, you want to see whether it's from the pituitary or ectopic from other places. So pituitary MRI, unfortunately, can be negative 40 to 60%, hence you need an IPSS. The new test that we can do is CRH PET CT scan, which is again not available in Malaysia yet. Right? Primary treatment, as mentioned before, surgery, transsphenoidal surgery. Post-operatively is very important because people will see killing patients what you monitor. So basically, we want to see whether this patient is in remission or not by looking at the cortisol. So remission is when a patient have a low cortisol or 24-hour urine cortisol within 7 days of post-operative, and usually they require replacement up to 12 months. Some may require longer. Remission is better with a microadenoma, but macro would be higher. So those who failed surgical or having a recurrence, you need to repeat the surgery if it's incomplete. Probably you want to offer radiotherapy or gamma knife. Medical therapy directed to which areas you want to direct, like pituitary, you want to give pasireotide, meteropon adrenal directed, or mifepristone if you want to block the glucocorticoid receptor. Other than that, the very end is when you have tried everything, you may want to go into bilateral adrenectomy, but this, bear in mind, patient need a steroid long time, and there's a risk of Nelson. All right, a bit on polyuria. As Dr. Ilyana has mentioned, polyuria is actually defined when it's more than 3 liters per day, and you need to rule out all the other confounding factors, and you see whether the patient having high osmolarity or not. If it's high, you need to rule out if there's any hyperglycemia, CKD. But if it's low, less than 300, we would proceed with, again, water deprivation as mentioned earlier, to differentiate whether these are the causes. Right. So can hypercortisolism occurs in the eye? If it's actually a true central DI, it's very rare. So patient may present with DI mimicking, whereby they have a nephrogenic mimicking DI because of the hypokalemia, which caused a patient to have reduce in water absorption, and so patient having polyuria. Other than that, your V2 receptor also will be reduced in expressing, hence reduced in water absorption. Also, the osmotic diuresis, once patient hypercord, they become insulin resistance, hyperglycemia, hence osmotic diuresis. So it can also mimic a central DI, whereby if you see here, once cortisol is high, so it's going to give a feedback mechanism and reduce in AVP and CRH. Hence, it may show as if a reduced ADH secretion and causing a DI-like symptoms. All right, so last, double pituitary adenoma is rare. So most of the double pituitary adenoma is actually GH with prolactin. So ACTH is reported by Ivocazzo in his study in Italy, whereby ACTH prolactin is more of a double pituitary that they find, 33%. Others is GH and non-functional, and about 10% is GH and prolactin. So 1 to 3% of them are having Cushing syndrome. And however, ACTH, and again, is very rare, Cushing disease with central DI. Whatever it is, MRI is very important in localizing it, and also operation to find out in visual answer. So our take-home message from this is that, again, double pituitary adenoma is actually having a multiple secretions finding as our patient, but can be very challenging to diagnose. So the diagnostic workup, as I said before, you have a screening, confirmatory, and also localization or lateralization. So localization, the gold standard for ACTH dependent would be IPSS, and you need to support with MRI. First line treatment is definitely remove the disease if possible. And in young population, Cushing's disease, you need to recognize early so that we may prevent the complication afterwards, such as in our patient. With that, I thank you.
Right. Thank you very much, Dr. Ilham, for a very nice presentation and sum up of the case. And thank you, Dr. Ilyana. You done well, right? Give on a chat. And thank you to Prof. Shahizon. Very clear explanation about how you describe the pituitary MRI and localization of the nodule. And unfortunately, Dr. Jasmine has to go off to attend a conference. And thank you to all of you for attending. I will not allow any question. You can approach the presenter because it's already 9 o'clock. We all have clinic to go to. Thank you.